Learn Simply Academy Vaginal Surgery Masterclass series. In this, we will talk about sacrospinous fixation and colpopexy, safe anatomical landmark, and suturing technique. Now, the clinical rationale is why sacrospinous fixation, a durable native tissue solution for apical compartment and loss of support. Why surgeon favor it? Vaginal route, avoid laparotomy or laparoscopic access, shorter operative time. Uses native ligamentous tissue, no mesh requirement for apical anchor. And preserve vaginal length and access when performed with attention to the angle fixation. Can be combined with anterior and posterior repair or vaginal hysterectomy and same system. Primary indications are vaginal wall prolapse after hysterectomy, uterine precedentia, enterocele with apical descent, and recurrent apical prolapse. Now, this is a relevant anatomy to the sacrospinous region. Ischial spine is a primary palpable bony landmark, marks the lateral extent to the sacrospinous ligament. Sutures are placed medial to it, never lateral or directly on it. Coccygeus muscle, thin muscles overlying the ligament, and the ligament and the muscles are often engaged together as a combined structure during the suture placement. Inferior gluteal vessels and nerve, these are the cords superior to the ligament near the sacral attachment and lead to the structure placement of the wrist injury. Sacrospinous ligament, it runs from the ischial spine to the sacrum, overlying the coccygeus muscle, a strong fibrous band used to anchor the wall fixation. Pudendal nerve bundle, pudendal nerve, artery, vein exists to the greater sciatic foramen and wrap around the ischial spine posteriorly. The most important structure to avoid. It lies medial and posterior to the ligament. Traction must keep the rectal wall to the medial path, and especially during the posterior passes. Now, the preparation is popcustation, assess the vaginal length, screen the prior pelvic surgery, radiation, infection, and assess the estrogen status. Consider vaginal estrogen 4 to 6 weeks preoperatively in a postmenopausal. Preoperative assessment and counseling, informed consent discussion, realistic success rates and possibility of reoperation, risk of transient buttock and gluteal pain, rare risk hemorrhage, nerve injury, rectal or bladder injury, effect on vaginal length, sexual function, and coagulation. Alternatively, the apical procedures are uterosacral suspension, sacrocolpopexy, colpoclysis, and rational to choose the approach. Now, instruments are single-handed loaded needle driver, which is we can use. And we can use a direct digital or visual control, minimum traction, operative time, roll rest, the blind process. Suture material is a proline, propylene, braided polyester or long-term ligament fixation. Delayed absorbable used in some surgery. Choice influences durability, risk of suture, erosion, and chronic disease. Positioning is very, very important. Highly thought in positioning, Trendelberg to displace bowel. Candy cane or the bout stirrups to adequate hip flexion and abduction. Buttocks position just past the table edge for the full posterior vaginal access. Bladder catheterized and emptied, vaginal packing available for hemostasis. Then achieve exposure is a right-handed, right-sided approach is conventional. Left-sided is equal. Incise posterior vaginal wall, sweep the rectum medially, adequate hemostasis of the space before proceeding, avoid obscured landmarks during sutures. Now, these are the techniques. First and foremost is identify the ischial spine and ligament. Palpation technique, just insert 2 fingers on the posterior vaginal wall towards the side wall of the palpate the ischial spine. It's a firm, discrete bony prominence, usually 1 to 2 finger breadth deep to the vaginal introitus. Trace medially the spine along the taut band-like sacrospinous ligament running toward the sacrum. Confirm the coccygeus muscle overlying the ligament. It feels slightly softer than the ligament. Reconfirm the landmarks. After the retractor placements, the tissue tension can change the perceived position. So, ischial spine, lateral anchor point, ligament body, medial 2 cm target zone. Coccygeus muscle overlies the ligament. Pudendal bundle, posterior to the spine, avoid. The safe zone is 2 cm medial distance from the ischial spine for the suture placement. Structures to protect prudental nerve, artery main, inferior gluteal vessels, rectum, and sciatic nerve. Now, vaginal wall fixation and tensioning, suture passage, provisional tie down, tensioning, and axis chain. So, pass the suture ends toward the two separate sutures should be used to ligament safe zone through the vaginal wall apex, and then approximate the wall toward the sutures and tension. Now, bilateral is good or unilateral, but unilateral is a standard approach, shorter operative time, anatomic support. It's considered for the advanced prolapse, distributes tension across both ligaments, but proportionately more room for the technical error. Now, we should combine the sacrospinous fixation with anterior posterior pair, yes, but sequencing is perform the sacrospinous fixation first, anchor the vaginal axis first, and then do the anterior posterior repair. And the posterior compared colpography are performed the same incision after the SSLF. Now, safety during the complication, hemorrhage is important. First, we should recognize breast bleeding, management, direct pressure, bleeding pulses, hemostatic suture, vaginal panking is important. If there is a nerve injury, patient report intraoperative concern applied 2 for lateral. Then management is suspected intraoperative, remove the suture, and persistent pain, remove the suture. Rectal injury, recognition is important. Prepare primary two-layer broad-spectral antibiotic and finish. Then what postoperative care? Monitor for hemorrhage, urinary retention, activities restriction, 6 weeks postoperative visit, 3 to 6 months reassure for normal activity, annually long-term surveillance for the recurrence of POPQ examination. So placing the suture lateral to the ischial spine, single most common cause of vascular nerve injury. Overtensioning in the fixation suture causes tissue ischemia and chronic pain. Neglecting or address coexisting anterior department defect, most common site of recurrence. Blind clamping to control bleeding is important. Delaying suture removal in the patient with severe persistent buttock pain. Then confirm the ischial spine by palpation. Middle 2/3 ligament 2 centimeters. Now the summary is the ischial spine is ischial palpable lemma, often confirmed before suture. The safe zone is the medial third of the ligament and more than 2 centimeters medial to the spine. These are the instruments which we can use on the training exposure, not without superiority. Avoid over-tensioning or approximating wall to the ligament without ischemic clinching. Transient buttock pain is common, usually self-limited. Persistent severe pain warrants suture removal. Sacrospinous fixation outcomes are comparable to the uterosacral suspension. Sacrocolpopexy remains durability the benchmark.